Mr. O'Connor.
My lady, our first witness this morning is Lord Stevens.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Could you give us your full name, please?
Simon Lawrence Stevens.
Lord Stevens, you have kindly prepared a witness statement for the inquiry at our request. A copy of the front page of it is up on the screen now. I'm sure you're very familiar with the contents of that statement, and we don't need to go there, but on the last page, you've signed that statement with a date of the 22nd of September of this year underneath the statement of truth, saying that you believe the facts contained in the statement are true. Is that right?
It is.
Thank you. Lord Stevens, you had a lengthy career in the NHS, latterly in NHS England, and of particular interest to the inquiry, you were Chief Executive of NHS England for over 7 years, between April 2014 and July 2021. Is that right?
That is.
And it's clear, therefore, from the dates that the final year and a half of your tenure as Chief Executive was during the COVID pandemic.
Yes.
We also know that you were made a life peer on stepping down as Chief Executive in 2021. Is that right?
Mm-hmm.
Lord Stevens, help us a little bit, if you will, with the nature of your role as Chief Executive of NHS England. Is it right that you were, as it were, the operational head of that organisation?
Yes.
It is, of course, an enormous organisation, enormous budgets, huge staff, buildings, and so on. Just give us an idea, if you will, as to the scope of your role in that post.
The NHS in England is not one and the same as NHS England, somewhat confusingly. So NHS England is the body that was created by Parliament in 2012, in the first instance to oversee the funding for different health services across the country. But as part of that 2012 Act of Parliament, actually quite a number of the responsibilities for the health system overall were distributed, some might say fragmented, between different bodies, of which NHS England was one, but Health Education England had responsibility for education and training, NHS Digital for the data, Public Health England for obviously not just infectious diseases, but PPE stockpiles and so forth. And so over time, frankly, we attempted to try and ensure that together pieces of the jigsaw were coming together to form the full picture. But the consequence of that is that in legal terms, at least, before a set of changes were made in 2022, NHS England was not actually directly responsible for the totality of what was happening in the NHS in England. Confusing as that sounds, but that is the legacy that Parliament bequeathed us.
Well, perhaps not responsible for the totality of the NHS in England, but what, in summary, was it responsible for?
Well, de facto, particularly when COVID struck, our job was to lead the NHS response.
Right. So that was the role of NHS England.
Yeah.
Your role within it as its chief executive, in summary?
To be responsible for the work of NHS England itself, and also to be directly accountable to Parliament as the accounting officer for the funding that flows to the NHS in England, which was about £150 billion a year.
Thank you. And that brings us to a point I wanted to raise, which is that we need to be clear, don't we, about the relationship between NHS England, but in this case you, and the Department for Health and Social Care and its Secretary of State, Mr. Hancock. Putting it crudely, he was not your boss, was he?
The Chief Executive of NHS England is accountable to the Board of NHS England. I must say, frankly, it felt as if I had many bosses. So the board of NHS England was one. I obviously had an accountability to the Secretary of State and to the government, but also more widely to Parliament, as I've described as the accounting officer for the organisation. And frankly, I felt an obligation to patients, the public and staff in the NHS as well.
Moving on to the pandemic itself, Lord Stevens, it is obvious that the NHS was involved really at every level of the response to the pandemic. And that involvement will find its reflection in the involvement of NHS England with this inquiry. There is, to follow this module, as you know, a module that will focus on the NHS itself. There will be vaccines module, there is a module to consider PPE, care homes, all of which the NHS will have a strong interest in.
Absolutely.
This module, as you know, is focusing on core political and administrative decision-making, essentially decisions about the pandemic made in Downing Street and the Cabinet Office. And so the scope of my questions today will be on the role that you and NHS England took, first of all, in that decision-making and also on issues that affected that decision-making. But we need to bear in mind that those operational matters, if you like, will be covered in subsequent modules. So let me start, if I may, by asking you, what role do you think that you played, in general terms, in that core political decision-making in the period that you were in office during the pandemic?
Well, I think the main responsibilities that we had and I had were to do everything we could to ensure that the NHS was able to look after severely ill COVID patients and also all of the other non-COVID patients who needed our care during the course of the pandemic. So first and foremost, it was about the operation and the availability of the NHS. We were not directly asked to contribute to debates that government was having about lockdowns and so-called non-pharmaceutical interventions or other ways of controlling the spread of the virus.
Just pausing there a moment, Lord
Sure.
Stevens, if you can try and keep your answers relatively, speak relatively slowly and relatively short, that would help us all.
Okay, well, I'll stop there then.
All right. So you've described, in essence, most of your work, unsurprisingly, given what you've said, was on operational matters, helping the NHS deal with COVID and, of course, deal with all of the other things it would have been dealing with anyway.
Yeah, I think that's right.
And you've said that you were not routinely involved in those discussions about lockdowns and other MPIs. We can see, and you describe in your statement, perhaps we can look at paragraph 13 of your statement on page 5. You say that you did attend several of the Cobra meetings. We've heard about these meetings held in the early part of 2020.
Yes.
Several, all, maybe you can't remember now.
Probably almost all. I know the inquiry has the Cobra minutes, and whether I was there or not will be there, but certainly a number during February and then in March. But as I think I mentioned, in a sense, Cobra fell out of use as a mechanism by which the government decided to take its decisions or review progress against the pandemic. So that abated as a forum for this type of discussion. Well,
We've certainly heard that the Cobra meetings stopped, but are you saying that you stopped going to them for that reason?
No, I think I went to every Cobra meeting I was asked to go to, yeah, as far as I'm aware.
And was it routine that either you or someone else from NHS England was invited to those meetings?
During February 2020, I think that's right, and probably March as well. I mean, I'd have to literally go back and look at all of the Cobras and the minutes and so forth, but that's my recollection, yes.
You've mentioned just now, and you describe in your statement, a view that these meetings were not, in your words, optimally effective. Can you expand on that?
Yes, My observation is that the Cobra meetings were very large, so lots of people, which often makes it hard to have very substantial discussions. And sometimes the seniority of representation ministerially at the Cobras varied between departments. So it wasn't always the case that a minister necessarily had the full authority of their department when a discussion was taking place, was my observation. Now, others in government may take a different view.
There's a particular point you make, which we can see in this paragraph on the screen, Lord Stevens, which is that when, as we know they were in the early stage, the Cobra meetings were chaired by Matt Hancock, other Secretaries of State sometimes avoided attending and sent junior ministers instead. Was that a reflection you had at the time?
I'm not saying that was cause and effect, but that is the fact of the matter.
Well, I'm sorry. The inference in your statement is that it was cause and effect, but you're not going that far.
Well, I just observed that those two coincided.
Can you offer a view as to whether, in light of that, the phenomenon that you were observing, it would have been better for the Prime Minister to have chaired the Cobras at the early stage? Would that have, do you think, ensured that more senior people, Secretaries of State, attended those meetings?
I think it's very likely that if the Prime Minister had chaired those Cobras, then other Secretaries of State would have chosen to go as well. But whether the substance of those Cobra meetings was such that not having all of those folks there made a big difference, I defer to others.
Of course. Just following down the page, Lord Stevens, you indicate that you did attend some cabinet committees, and I think we can see, I'm not going to take you to the document, but you were an attender, were you not, of the MIG, the health? There was a particular health MIG early in 2020, which I think you did attend. Is that right?
Yeah, I think I went to several of them, but not all of them. And as I think I perhaps diplomatically say in my statement, I did not consider that they were the most effective forum for resolving operational questions, shall we say. And that's why, in fairly short order, they were abolished and replaced by a different system.
They were replaced by what I think everyone referred to as COVID-O, COVID-S, operational and strategy.
Yeah.
I think you're saying that your MIG was replaced essentially by COVID-O. Is that right?
I think all of the MIGs were, in a sense, replaced by COVID-O and COVID-S. The point being that I think having fragmented, subject-specific ministerial groups didn't really deal with the cross-cutting issues, which actually were the main purpose of having those kinds of forums. And when it came specifically to figuring out things that required political involvement, a ministerial decision on health, the MIG was probably not the best place to get that done.
Did you attend either COVID-O or COVID-S, and did you find that they were more effective forums for the
Yes, I did from time to time, and that was my assessment. And as I think I say as well, I think when the Cabinet Office created with Number 10 this thing called the COVID Task Force, that substantially improved the coherence of what the central government was doing relative to individual government departments, was my impression.
You also say in your statement, Lord Stevens, that there were a few occasions at least where you had ad hoc meetings with the Prime Minister and other senior decision makers.
Yeah.
And I'd like to take you to a document which records one of those meetings. It's 146616, please. So this, Lord Stevens, is an email, is it not, dated the 10th of October 2020, so we're in the autumn of that year. And it's an email from Imran Shafi, who's given evidence to the inquiry, essentially recording a meeting which had happened, I think, earlier that week. And we can see from the start, the first line of the email, it was a meeting which included the Prime Minister, the Chancellor, Chris Whitty, Stuart Vallance, and you. And it may well be others as well.
Sure.
We don't see your name on the copy list. This appears to have been an internal sort of number 10 document. But I know you've had a chance to look at this document, and obviously if there are any things in it which don't accord with your recollection, you'll tell us. First of all, do you remember going to this meeting in the autumn of 2020? I say going, it may have been a virtual meeting.
Yeah, I do remember it. I think this note is the 10th of October. I think it relates to a meeting that Thursday. I think it was probably the 8th of October.
Right. And we see again from the first line that the purpose of the meeting was to discuss COVID, but perhaps in particular NHS preparedness. Mm-hmm. Preparedness for the winter to come?
Yeah. And in the light of rising COVID cases, which were apparent by early October.
And we'll look at just a little bit of the detail in a moment, but before we do, can you give us a sense of how frequent meetings like this were? Did you have meetings with the Prime Minister and the Chancellor weekly, monthly, less than that?
It ebbed and flowed. So during March 2020 and April, very frequently. Then as COVID numbers decreased and the pressures on the NHS likewise, then far fewer during May, June, July, August. But then from October, they increased again. And certainly by the time we were in, say, late December, early January 2020, very frequently. In fact, I think I had between New Year's Day and the 10th of January, something like 6 separate meetings with the Prime Minister and others on both winter COVID pressures and the vaccine rollout. So that was the sort of pattern of it over the course of the pandemic. As I think I also say in my statement, Number 10 got into this sort of rhythm of having these so-called daily dashboard meetings at 9:15 that the Prime Minister would chair, and their frequency kind of changed a bit depending on what was happening with COVID. They could sometimes be every day, they could be 3 times a week, and I personally found those very useful sessions because it was a chance to kind of tell it straight, direct to the relevant senior politicians, and to the extent there were things that, frankly, I thought we could benefit from some support on, to sort of lodge that direct with the Prime Minister and others.
Just helping us to imagine what you're describing, Lord Stephen, can you just give us an indication of whether those meetings were virtual or not? I mean, were you spending your life going back and forth to Downing Street when you were having these regular meetings, or did you, for example, dial into those 9:15 meetings?
Yeah, some were virtual and some were face-to-face. So yeah, it was absolutely a mix of both.
We will come to the detail, but since you've given us that overview of your interplay, the exchanges you had, the meetings you had with the Prime Minister and his team, you are of course aware that we have heard evidence in the last few days, the last week or so, of difficulties in the decision-making process, a certain level of dysfunction. There's been evidence of the Prime Minister finding it difficult to settle on a particular decision. Oscillating is one of the words that's been used to describe that. Can you give us an overview of your experience of those months that you spent discussing COVID, helping him make those decisions?
Well, in a sense, I don't think I did help him make those decisions, if by those decisions you mean lockdown decisions, social restrictions, and so forth. So
just pause there.
Can't.
What I meant, because you have just given evidence that you had frequent meetings with the Prime Minister.
Sure.
At times very frequent.
Yeah.
I'm not suggesting that you were making the decisions with him.
Sure.
But one assumes that the purpose of him having those discussions with you was to help him make decisions. That's what I meant.
Yes, but Actually, the way the rhythm of it tended to work was we would have the session specifically on the NHS, and then ministers would go off and have a separate session without the NHS present, where then the consequences of that for their wider decision making would be taken account of. So I think a lot of what you've heard, as I understand it, over the last several days really relates to sessions that, frankly, I was not present at, so I can't give you good commentary on those.
You would, though, have experienced the consequences of his decisions, and you would have found yourself at the next meeting hearing that a decision you might have expected to have been taken either had or hadn't been taken. So is there really nothing that you can say about the way in which the decision-making process took place?
Well, I mean, obviously, I can see some of the evidence that you can see now as well, not all of which, obviously, we were privy to at the time. What I would say is that in respect of decisions that we needed from government on NHS capacity, I mean, sometimes decisions were taken which we didn't like, but nevertheless, those were the decisions. I think the best example, in a way, of the sort of interface with prime ministerial decision making that I can personally speak to was around the rollout of the vaccine programme, where the Prime Minister was very personally involved in that, and for the most part, that was actually a constructive engagement on what needed to get done, and we can obviously talk specifically about that. But
yes, right. Well, we won't, because as we said, there is another module to come, and I'm sure there will be an opportunity for you to talk about vaccines in the vaccines module. Let's look, if we can, at this document, and it's perhaps the third paragraph, where we see that the PM asked about NHS capacity, and there's then a record of a relatively detailed review, if you like, that you conducted of the position as it stood regarding the NHS. We see reference to regional variation, and we also see in the first line that you stressed the NHS was not overwhelmed.
On the 8th of October 2020, correct.
Exactly, and so you are saying it wasn't overwhelmed at the time of the meeting, and then reading on, you describe the regional position and give some view about the future. And I'm going to come back to the question of NHS overwhelm shortly, but just looking a little bit further down the document, there's the next paragraph we see that the discussion turned to the question of MPIs. Simon Ridley, one of the Cabinet Office officials, gave a presentation about MPIs. Then there's another paragraph where it appears that you contributed to the debate, perhaps about MPIs. It says, Simon Stevens argued that, stepping back, not everyone currently accepted there was a problem. People did not think measures were fair. They questioned whether they worked, and if they did work, they wanted financial support. Government response should take these factors into account. So first of all, slightly contrary to what you said a moment ago, this does appear to suggest that you were contributing to discussions beyond simply the NHS capacity matters.
Well, I think on this occasion I was asked, what are people in the health service in Liverpool, Merseyside, the North West seeing about what's happening in their local situation? Because obviously part of my responsibilities were often to be out and about around the country talking directly to people who were affected. And I think in that comment I was reflecting what I had been told directly from people in Merseyside, Manchester and elsewhere, that frankly the set of mechanisms that were then supposedly in place in those areas were not working. And their view was that part of the problem was that there wasn't sufficient financial support for people who were being asked to self-isolate. And so when I was asked the question, I answered.
Yes, and in fact one of the themes of the evidence that we've heard is precisely on that issue, that there was a live question about whether sufficient financial support was being provided, including, in fact, to workers in the healthcare sector. And I think, are you saying that perhaps it was workers in the healthcare sector that you were reporting back on, as it were, needing further financial support?
You know, I can't. I can't remember that specifically because obviously there were different arrangements for NHS staff, furlough, and so forth. So I can't say that directly. But what I can say is that I think this was a time, as I recall it, when it was a pretty variegated set of local restrictions that were in place around the country. And frankly, a lot of people were struggling to understand the rationale and what they were supposed to be doing in one place or another. And I think it's the case that after this, the government then moved to their more sort of clear-cut tiering system to try and respond to that.
Quite. And on any view, you were voicing support for the idea that further financial support needed to be given to people self-isolating.
That was my personal view. I think actually what these notes show was that I was describing what I'd heard other people saying, but yes, that was also my personal view.
Thank you. I'm going to move away from this document, but stay, as it were, with that general issue of exchanges between you and the Prime Minister. Mm-hmm. And I'd like to go, if we can, please, to the written witness statement of Helen McNamara, which is 273841, paragraph 71. On page 39, I think. Yes. Lord Stephen, I don't know if you've had a chance to look at this document before. I hope you have.
Sorry, which part are you looking at?
Well, let me show you. One of the observations that Helen McNamara makes in her witness statement, and in fact that she expanded on in evidence yesterday, is the last sort of 5 or 6 lines of this paragraph we're looking at. She, of course, is talking about her experience of dealing with officials and politicians in Number 10. But she said this: "I don't remember anyone working in the centre or who was part of the conversations who had a detailed understanding of the way the NHS operated. This is not unusual or unique." And she talks about the fact that social areas of policy are less well represented in Downing Street than military, national security type matters. Mm-hmm. Interested in your views on that, with your long experience of dealing with politicians, but perhaps particularly that period during the pandemic. Did you feel there was, as it were, a deficit in their understanding of the granular way in which the NHS works?
I think Helen's description seems to me accurate, particularly as regards the Cabinet Office. The extent to which the Prime Minister's Office, Number 10, has health expertise is to some extent a function of how the Prime Minister of the day chooses to staff their Number 10 policy unit. During the pandemic itself, I think there is truth in what she says, but to some extent, as long as that doesn't lead to ill-informed second-guessing of the decisions that people in the NHS are actually trying to take, that need not in itself be a problem.
One can certainly see how it would be a problem if there was that sort of second-guessing, but surely even if they leave the operational decisions to you, it would still be necessary for them to have that level of detail in making the higher level decisions, for example, MPIs and so on.
Yeah, I think to some extent that is true. I mean, I think there was as I think Helen described, and I agree with her, there was a sort of disconnectedness between aspects of what the Cabinet Office was doing early on in the pandemic and what sort of we were seeing in terms of the operational realities. As I say, I think the COVID task force really helped with that because that brought together people who had that more detailed set of expertise into one place with a single voice where you could have a direct conversation and know that the advice that would then go to the Prime Minister or others would be properly informed by what we were telling them.
And just sticking with that then, we'll hear more about the COVID task force, in fact, in evidence next week. But
right.
Help us with this. Were there people, civil servants, involved with the task force who had this sort of granular understanding of the NHS in a way that perhaps the earlier structures didn't have?
I think to a greater degree, yes. And there were some, even if there were some generalists, they, I think, pretty quickly understood the moving parts, shall we say.
I want to move to a slightly different topic, Lord Stevens, and it's still to do with your engagement with the Prime Minister and Mr. Hancock and others. But it's a rather basic question of whether Mr. Hancock in particular, but others, were encouraging you to resign or otherwise remove you from office during the period of the pandemic. I'll take you to some documents, but were they or not?
No.
Let's
Not
look,
to my face, anyway.
let's just look at a couple of WhatsApp messages, if we may. First of all, 129176. Let me say these are both these messages are from very early in the pandemic, but you can see January 2020. Dominic Cummings is texting to the owner of the cell phone, who is Mr. Hancock, saying, "Where are we with SS Simon Stevens?" He says, "It's in train. I'm first getting Ara Darzi to persuade him it's in his best interest to go now. If that doesn't work, I'll move directly." And then if we can go, please, to 129185. 10 days or so later, the 3rd of February, it's just at the top, Dominic Cummings says, "When SS off?" Matt Hancock says, "Wanted to talk to you about this in the margins of meeting tomorrow." Short answer is his initial proposal is to announce in September and go at Christmas. I haven't yet engaged how hard to push for sooner. Dominic Cummings says, "We must get on with it now. Announce next week as part of reshuffle frenzy, and then it will all get lost in that." Matt Hancock says, "Let me see if I can square him for that. If I can't, we can still go if we want." So at least on the basis of these messages, first of all, there certainly do seem to have been discussions between Mr. Hancock and Mr. Cummings about you leaving, and it does appear that Mr. Hancock had had some discussions with you about that.
Well, take a step back. I, as you said at the start, was appointed in 2014. When I took up post, I envisaged serving for around 5 years, which would have taken me to 2019. As you may recall, there was a degree of political chaos in the United Kingdom during the course of 2019, a change of Prime Minister, a general election, and I therefore did not feel it was quite the right moment to create a gap in the leadership of the NHS. So I think it was known that that was something that had been in my mind, but felt that I should stay through to the new year and then sort of make a decision at some point during the course of 2020. Now, of course, COVID then came along, and it would have been completely wrong to have left a vacuum during the first wave of COVID. Come summer 2020, the thought recurs, but I have a discussion with the Prime Minister about that during summer 2020. But by the time that possibility would crystallise, we were back into another wave of COVID. So I therefore, again, felt duty-bound to see the winter period through and then the rollout of the vaccine, at which point, in July 2021, I was able to leave.
Yeah. Well,
but by the way, can I just say on some of these things, I think there's a suggestion there about asking Lord Darzi to persuade me. These emails, I think, have previously been leaked to the Daily Telegraph, and in response to those, Lord Darzi has said on the record that is not correct, and I think his actual word were, that is misinformation. So he did not seek to persuade me in the way that's described here.
well, thank you for clarifying that and for the earlier answer, Lord Stevens. And let me be clear, the reason that I'm asking these questions is to understand whether there was a relationship of confidence and trust between you doing your very important job and Matt Hancock, Boris Johnson and others during the period of the pandemic. And I think it follows...
Well, can I just say on that? I think it's relevant, as I saw Dominic Cummings' statement earlier in the week. I think he has said on the record that when the pandemic struck, he was then not seeking to do this. And I believe Matt Hancock has said the same in his written statement. So I have no insights other than what the two of them have said on the record.
And your evidence, putting those exchanges in context, is that there was no sense in which you were somehow defying them in staying in your role in January, February 2020.
No.
And I do want to ask you about one more message, which is from later in the year, August 2020. I'm not going to bring it up on screen, but let me just read it out. Its primary focus is Mr. Cummings coming back to the question of whether Mr. Hancock should leave his role, but he does mention you as well. He says this: "I must stress that leaving Hancock in post is a big mistake. He's a proven liar who nobody believes or should believe on anything, and we face going into an autumn crisis with him in charge of the NHS still. Therefore, we'll be back around that cabinet table with him and Stevens bullshitting again in September. Hideous prospect." So, leaving aside the question of Mr. Hancock, did you, later on in 2020, in August, have the impression that Dominic Cummings or Boris Johnson was dissatisfied with the way that you were running the NHS or bullshitting them?
Well, by the standard of Dominic Cummings' adjectives, that's one of his gentler epithets. Look, what I would say is, well, I just said it a moment ago, actually, I did have a discussion with the Prime Minister in the summer of 2020 about whether or not I would be able to be released from active duty in the NHS. We discussed specifically whether I might play a role in helping improve social care in the country. To be frank about it, I was pretty clear-cut about what I thought success would look like if we were going to improve social care, that it needed to be not just about ensuring that people didn't have to sell their homes, but also that the availability of social care increased and that the social care workforce was addressed. I was clear that I didn't think this could be done just as a private Whitehall process, a sort of behind the bike sheds agreement between ministers. It had to be a public, open process. And ideally, if it was going to create a national consensus, so social care reform actually got done, it needed to be on a cross-party basis. That was the basis on which I suggested action was required. Those points did not find favour, and therefore I didn't do it.
Did you think that Boris Johnson, Dominic Cummings, trusted you to do your job during the summer and autumn of 2020?
I can't speak for Dominic Cummings, but there was nothing, because I had no conversations with Dominic about this question, but my regular interactions in the autumn with the Prime Minister did not give me a different sense of that, no.
And what about Mr. Hancock, Mr. Stevens? It is important to understand whether there was a fruitful relationship of trust between the two of you, that the inquiry has heard evidence that other people working with Mr. Hancock found him someone who was untruthful. Was that your experience or not?
There were occasional moments of tension and flashpoints, which is probably inevitable during the course of a 15-month plus pandemic. But look, I was brought up always to look for the best in people.
I'm sorry, Mr. Stevens, that's not an answer to my question.
Which question? Which bit of it?
Did you find Mr. Hancock to be truthful or not?
Well, I know various people have made quite strong accusations against Matt Hancock. All I would say is strong accusations need strong evidence to back them up, and I don't think I've seen that evidence.
I'm still not sure you're quite engaging with my question, Lord Stevens, and it is important because you were at the head of the NHS, he was at the head of the Department for Health and Social Care. In your working relationship with him during these most extreme and important of times, was he someone you found you personally could trust?
Yes, for the most part, yes.
What do you mean by for the most part, Lord Stevens?
Well, as I think I said right at the start, I'm not denying that there were a small handful of occasions during the course of the year and a half, when there were tensions. But that, I don't think, is particularly surprising given the circumstances under which everybody was working.
I'm going to move on to ask you some questions about something called Operation Nimbus. Let's look, first of all, at your statement, please. Paragraph 21, page 7. I think it's right to say you attended this operation, which was a tabletop training exercise.
Yes.
I'm not going to call it up, but we can note that it was an exercise that was implemented following a a Cobra meeting on the 29th of January. We could see it in the minutes that there needed to be an exercise. And as I think we've said, it occurred about 2 weeks later on the 12th of February 2020. Can you just describe in a few sentences, Lord Stevens, what that exercise was about and what you took from it?
Yes, the purpose of the exercise was to look at the so-called reasonable worst-case scenario, which I know the inquiry's heard evidence about, which is saying if it's the case that COVID turns out to have these features, maybe 81% of people are infected and a proportion of them then die, that obviously is a huge and devastating impact on the United Kingdom. What are the responses that different government departments need to make? And so I think it was less specifically aimed at the health response and more about having a broader range of Whitehall departments who had not been so involved in those conversations, kind of getting their head around, my goodness, this would be an absolutely terrible thing. What would we need to do to make sure our plans are prepared?
We haven't actually seen any report or summary from this exercise.
Right.
Do you happen to know whether such a document existed, or would you have expected such a document to exist?
Yeah, I would have assumed that the Cabinet Office relevant secretariat would have produced some sort of notes from that, actions for departments, whether they have or not, leave to you, but I would have thought so, yes. I mean, I might also say that, in a sense, the effectiveness of this exercise was slightly undermined by the fact that this took place on the 12th of February 2020, with a lot of ministers from a range of departments other than health around the table. And then the very next day, there was a cabinet and ministerial reshuffle, and quite a number of them lost their jobs. So it was an entirely new set of ministers who had not been exposed to any of that 24 hours before.
I was going to ask you, without wanting to stretch your memory too much, in fact, who was there? Do you recall whether the Prime Minister was there?
I don't think he was. No, I don't think so. But I'm sure there will be records to that effect.
We haven't seen any, but we can carry on looking. But I think it's implicit in what you say then that certainly I think Mr. Hancock was there.
Yeah.
We'll come on to talk about that. And other junior ministerial people who, as you've said, some of whom may have lost their jobs or changed their jobs the next day.
Yeah.
Let's look at what we do have about Operation Nimbus, Lord Stevens, which is, if we can call up on screen, please, INQ 52022. This is a set of, I think, slides. It's perhaps a PowerPoint demonstration. It's perhaps what the participants in the operation were shown, or at least part of what they were shown. And if we can go to page 7, please, we see the synopsis, which is very much as you've already outlined. It is to be imagined that the COVID pandemic has advanced, as it were. We see that the participants are asked to imagine that the date is the 14th of April, excuse me, so 2 months further on from the 12th of February, which was the date this took place. Sustained transmission has been ongoing for a month and a half, hypothetically, by that stage. There are various facts and figures given, but the most striking one is in the last bullet point, which is that it is, as of the synopsis, to be assumed that there may be around 840,000 excess deaths over the 16-week wave of infection, which, as you say, reflects the reasonable worst-case scenario at the time. Is that fair?
Yes.
And then if we look over the page and we see a wave, which was the scenario that was being engaged with, the sort of solid line is the hypothetical line up to the date of the exercise, and then there's a sort of projected dotted line after that. Mm-hmm. The wave lasts for 16 or so weeks, and the idea is that within that time there would have been that very large number, 840,000 excess deaths. Mm. Just a couple of points I want to ask you about leading on from that. The first is that, as you describe in your witness statement, this exercise seems to have provoked a discussion about who should be responsible for making decisions about prioritisation, allocation of stretched NHS resources in a situation like this. Perhaps we can take this down and look at paragraph 21 of your witness statement. It'll come up. It's on page 7. Sorry, perhaps I should have said that. So it's at the bottom of the page. So we can see, Lord Stevens, you say it, that is the exercise, did result in, to my mind at least, an unresolved but fundamental ethical debate about a scenario in which a rising number of COVID patients overwhelmed the ability of hospitals to look after them and other non-COVID patients. The Secretary of State, that's Mr. Hancock, took the position that in this situation he, rather than, say, the medical profession or the public, should ultimately decide who should live and who should die. And then you say, fortunately, of course, that dilemma never actually crystallised. Just before I ask you about this, to note that, is it right that the previous Secretary of State, or possibly a previous Secretary of State, but Jeremy Hunt, had taken a different view of this matter, had he not? I think it was connected to exercise Cygnus, which had happened some years before. He had taken the view, and this is in fact something that he spoke about in evidence in Module 1 of this inquiry, that decisions of this type ought to be reserved to clinical staff. Is that something you're aware of?
Yes, I've heard Jeremy Hunt say that, yes.
So there you are. I mean, he took one view, and you're saying in your statement that on the 12th of February, Mr. Hancock took a very different view. Did you have a view as to whether that was an appropriate line for him to take, desirable or not?
I thought it would be highly undesirable other than in the most extreme circumstances, and you can argue that these are the most extreme circumstances, and that is one of the reasons why the Department of Health and Social Care, I think, created a ethical and moral advisory panel to sort of ask the question, if absolute disaster strikes, then how would you ration care, limit it in a way that would be fairest and have the, be the most defensible under this, horrible situation. But I certainly wanted to discourage the idea that an individual Secretary of State, other than in the most exceptional circumstances, should be deciding how care would be provided. I felt that we are well served by the medical profession in consultation with patients to the greatest extent possible making those kinds of decisions.
And this, I suppose, was Operation Nimbus doing its job in the sense that it raised in advance an issue like this while there was still time to think about how to deal with it. And did you then take steps to at least pursue that debate as to whether Mr. Hancock should have that level of decision-making in a worst-case scenario?
Well, I think, and this is something that I think you're seeing Sir Chris Wormald from the Department of Health and Social Care later. That was probably something that Chris Wormald may be able to give you information on as well. As I say, the department had this moral and ethical advisory group, and I think they continued in existence during this period. So I actually don't think this was a question that was resolved. There were specific instances that gave rise to this type of question. At one point during the first wave, there was a group that had come up with essentially rationing criteria that might be used for critical care in the event that there were not enough critical care beds for severely ill patients. My view was that actually by the time that was drawn up, it was clear it wasn't going to be needed. And in any event, it was far too crude a tool that would result in bad decisions being made around the country. So that was never promulgated.
I want to move to a second issue, sort of stemming from Operation Nimbus, Lord Stevens, which takes us back to this question of the NHS being overwhelmed. We know that a month later than Operation Nimbus, the 12th of February, we know that on the 13th of March or thereabouts, there was a change of policy from the mitigation strategy towards a suppression strategy, which in the end involved a lockdown. And we also know that one of, if not the key rationale for that change of policy was a fear of the NHS being overwhelmed unless the policy was changed. But we've also heard from a number of scientists who sat on SAGE, who, in summary, have said that it in fact was obvious or fairly likely or very likely to them that the NHS would be overwhelmed sometime before the 13th of March. And they, I mean, for example, Professor Medley, who I'm sure you know, the chair of SPI-M, said that throughout February it became increasingly clear that NHS capacity in the UK would be overwhelmed. And just looking at this Nimbus exercise, it's inherent in what we've been saying about decisions of life and death and so on, that the exercise that was run there had as part of its core a situation in which clearly the NHS would have been overwhelmed. So just drawing those strands together, from your perspective, was it as late as the 13th of March or thereabouts that it became obvious, and only then did it become obvious that the mitigation strategy would involve the NHS being overwhelmed? Or is it something, to your mind, that was apparent earlier, or at least should have been considered earlier?
I think it was clear that if the reasonable worst-case scenario were to come about in the UK, then the NHS would be overwhelmed. And we had a group of our clinicians and analysts working, for example, intensely with the SPI-M modelers on Sunday, the 1st of March, to refine what the parameters might be for thinking about how many intensive care beds each sick patient might need and so forth. And that produced a set of scenarios that evening, Sunday the 2nd of March. SAGE papers, as I see them now on the 3rd of March 2020, have two separate papers, one from Imperial, one from the London School of Hygiene and Tropical Medicine. SAGE on the 3rd of March says three things. It says it is highly likely there is sustained transmission of COVID-19 in the UK at present. Secondly, they say, given current surveillance systems, it will not be possible to time the start of interventions optimally. And third, they say, whatever the exact figure, NHS demand will greatly exceed supply in a reasonable worst-case scenario, even with behavioural interventions and behavioural and social interventions. So I think it is apparent that certainly by the beginning of March, it could be seen that if action was not taken to reduce the growth of COVID, then the NHS would be overwhelmed.
Thank you. And one of the issues that we are considering is whether advice from bodies like SAGE was clear enough, and maybe that your reference there to the minutes slightly makes the point that sometimes these messages can be confused. But what I really want to get to is your own view, not with hindsight, but at the time. And do I take it from what you've said then that, first of all, the 12th of February, so Operation Nimbus, although the exercise involved a set of facts which included the NHS being overwhelmed, are you saying that at that stage, because it was still then a worst-case scenario, it perhaps wouldn't be fair to say that at that point it was clear that in reality, really, the cards were on the table and the NHS was going to be overwhelmed at that stage?
Yeah, as you say, I want to be very careful of hindsight bias, but I think Nimbus was explicitly presented as a scenario, as a possibility, as an exercise. It was not being suggested by the epidemiologists or anybody else that this is the course we're on, so now plan against it. And I think I make the point in my written statement that one of my observations looking back is that there was too much ambiguity about what the status of this reasonable worst case scenario was during the course of February and the first part of March. And the probability that the reasonable worst case was actually going to become the case. Obviously, that probability evolved during the course of February and early March. But I think, for example, minutes of the Cobra meeting on the 29th of January say that, informally at least, it was thought there was a 90% probability that the reasonable worst case scenario would not come to pass. And then sort of a few days later, early February, I think it was said there was a 4/5 probability that it wouldn't come to pass. But I think one of the takeaways from this is that there needs to be much greater clarity about what is the probability that is being assigned to these different potentials, so that policymakers can understand what exactly they're being told.
I mean, one way of looking at it, and this is, I think it was Professor Woolhouse who said this, is that the point of having a reasonable worst-case scenario is that that's what you should be preparing for. And so, in a sense, you leave aside the probability of that situation eventuating, you just prepare for it. But I think perhaps your point is that that might be a slightly it's too difficult to achieve that situation in real life. People are always going to want to know how likely it is that this sort of terrible event is going to happen.
I make the point, I think, elsewhere in my statement, that the government obviously has has a national risk register, and there are all sorts of reasonable worst-case scenarios in that. If we were actually to act on all of those, i.e., give them a probability that on the balance of likelihood they're going to come about, then life would grind to a halt. So at some point when these national risks begin to crystallise, you have to be clear as to whether you've moved from a purely theoretical possibility to this thing is happening, do something.
Let me move the conversation on, Lord Stevens, but sticking with this question of NHS overwhelm just for a few more minutes. We've been focusing on March 2020, but it's right, isn't it, that the later lockdowns towards the end of 2020 and then into 2021 were also triggered, amongst other things, by a concern that without it, the NHS would again be overwhelmed. Of course, then much more water had flown under more bridges. Do you think that later in the pandemic there was a clear sense amongst decision makers of what NHS overwhelm actually meant?
Yes, in the sense of, look, I mean, if you're confronted with a situation where you have, say, 100,000 hospital beds in England, and you're being told that if the pandemic runs out of control, you might need between 200,000 and 800,000, then, you know, that's orders of magnitude above what can be created. You cannot clone a new NHS in 8 to 12 weeks, and you certainly can't clone 7 of them. And by the way, nor can any other country, and the same exact issues were being confronted in France and Germany and Spain in winter 2021 as well. So that's, I think, the sort of first point to make. The second point to make, though, is that by the time we got to autumn 2020, actually, we obviously knew a lot more about the virus. Hospitals had done a lot of work to create the ability to turn on so-called surge capacity, extra critical care or other beds as cases rose. And we had new treatments for COVID and so forth. So taking, as it were, England as the unit of analysis and saying just is the NHS overwhelmed or not overwhelmed in a binary way kind of misses the point, because actually you have a graduated set of negative impacts as COVID pressures increase on the NHS. But I would make another point as well, which is that I personally do not think solely viewing the amount of COVID through the lens of whether or not there are NHS beds to cope for severely ill patients is by itself the right lens, because even with unlimited hospital capacity, if you have large amounts of coronavirus for vulnerable people, lots of people will still die. So the right question is, how do you control the increase in the numbers infected, not just how do you match the number of people who are going to be very, very ill to the number of hospital beds?
Thank you. And as you say, that's a point which you develop in your witness statement, and it's what I wanted to ask you about, which is, did you feel that taking the risk of NHS being overwhelmed as, if you like, the switch, the trigger for lockdowns, was the right approach for the government to take?
Well, it was clearly highly desirable to avoid a situation where ill patients weren't able to get the healthcare that they would benefit from, and we did, I think, for the most part, achieve that. But by itself, that, if you're interested in saving lives, is not the only goal.
Let me take you, please, to a different issue, and it is the question of the discharge of patients from hospitals into the community, into care homes in March 2020. Now, as you know, that's a set of issues which has already been, amongst other things, subject to litigation, and it will also be addressed in a module of this inquiry. So I don't want to go into it in any detail, but there is one issue that is raised in Mr. Johnson's witness statement for this module, and which you touch on as well. And so I'd like to address that, please. And can we do it by going to Mr. Johnson's witness statement? Excellent, we have it on the screen. And it's paragraphs 330 to 331. So starting at the bottom of the page, we see that Mr. Johnson notes that on the 17th of March Cabinet meeting, there was a note that over 30,000 patients were imminently expected to be discharged from hospital and into social care. If we can go over the page.
Yeah, just to clarify, it wasn't that number. I wasn't at that meeting, but I do see that the full Cabinet did discuss that question before the policy was announced, yes, on the 17th of March.
This is really just setting up Lord Stevens, Mr. Johnson's evidence, and then I'm going to ask you about it. So he describes, as we can see, on the 22nd of March, being provided with a copy of a DHSC document. Covid-19 response was discussed. There was an estimate in that document that between 12,500 and 15,000 hospital beds could be freed by postponing non-urgent elective operations, and that potentially 15,000 further acute beds were being occupied by patients awaiting discharge or with lengths of stay over 21 days.
Can I just clarify one point? Sorry. Although that may well have been in the Department of Health and Social Care's draft on the 22nd of March, that information had already been presented to and discussed with the Prime Minister on the 12th of March.
Yeah, I'm not. It's a quite a high-level point I want to take you to, Lord Stevens. So don't worry too much about the chronology or the dates, or the numbers. If we can go to the next paragraph, please. It's really this is the core of it. Mr. Johnson's position. He says it was very frustrating to think that we were being forced to extreme measures to lock down the country and protect the NHS, as we've said, protect it from an overwhelm, because the NHS and social services had failed to grip the decades-old problem of delayed discharges, he says, commonly known as bed blocking. And he says that before the pandemic began, he was trying to address that. Mm-hmm. Now, that's the point, whether, if you like, I think as Mr. Johnson might say, he'd been painted into a corner of having to have a lockdown, in part because of people he describes as bed blockers. And that's something that you address in your witness statement, and perhaps we can go to that, please, on page 12 and footnote 9. We really will have to expand
reading spectacles at this point, yeah.
I mean, Lord Stevens, this is the part of your statement where you address that assertion.
Yeah.
And in summary, you don't accept it. Let's not read that out. Can you tell us in your own words what your response to Mr. Johnson's line is?
Well, I think Boris Johnson is right to point to the fact that there have been long-standing problems with the availability of social care that has often meant that patients end up stuck in hospital when they could be being looked after at home. That is, without a doubt, correct. However, if you think about his suggestion just a moment, even if you accept that there were 30,000 hospital beds full in that way, which I think is certainly at the high end of what most people would estimate, but even if you think it's 30,000, we, and indeed he, were being told that if action was not taken on reducing the spread of coronavirus, there wouldn't be 30,000 hospital inpatients. There would be maybe 200,000 or 800,000 hospital inpatients. So you can't say that you would be able to deal with 200,000 or 800,000 inpatients by reference to 30,000 blocked beds. So I don't think the maths works. I mean, another way of saying it is, even if all of those 30,000 beds were freed up, for every one coronavirus patient who was then admitted to that bed, there would be another 5 patients who needed that care but weren't able to get it. So, no, I don't think that is a fair statement describing the decision calculus for the first wave. And, by the way, I think when you look at the second wave, when actually a lot of these problems have been addressed by the Treasury funding a lot more community health services and social care, getting rid of the means testing. So, in a sense, that problem had been significantly addressed. The Prime Minister still decided to have second and third lockdowns with this problem having been substantially resolved. So, for both reasons, I think that is that suggestion doesn't stand up to scrutiny.
Thank you. Another issue, please, and this time it's a question about PPE.
I think I'm guessing that I'm being asked to take a break now.
Lady Sedley.
I hope you were warned, Lord Stevens, that we take regular breaks. I shall return at 25 past. Mr O'Connor.
Lord Stevens, I want finally to ask you a set of questions about PPE. I think I may have said that right before the break, with the same caveat as the questions about the discharge of patients in March, in the sense that, of course, detailed issues about PPE will be covered in another module. But this just picks up on some evidence that Helen McNamara gave yesterday. And so if we could go to Helen McNamara's statement, please, 273841, page 53, paragraph 104. When it comes up on screen, Lord Stevens, we will see that this is a part of Ms McNamara's statement where she is describing various initiatives she took in the early months of the pandemic to try and effect certain changes or encourage issues to be addressed. And we will see about halfway down this paragraph, one of those issues that she became concerned about related to what she describes as the inadequacies of PPE for women. And she says she tried to make sure this was taken into account in any new supply. She gave evidence about that orally yesterday, and we looked at an internal email in which she raised this issue in mid-April with Simon Ridley and Mary Jones within the Cabinet Office, and that she was then told by another official within Downing Street, Cleo Watson, on the 30th of April, that the matter had been raised. And her evidence, as you can see, is that it was the Prime Minister who raised this issue with you on the April the 30th, 2020, and that you reassured the Prime Minister and ministers that the issues with PPE fitting women's bodies were misreported and that there wasn't a problem. Do you recall that?
Well, first of all, Helen was absolutely right to raise this issue because there were real concerns and we were very concerned about it and we were taking action. So she raised it within the Cabinet Office, as you say. As it happens, we were already acting, and in fact a week before this meeting, the Chief Nursing Officer, the National Medical Director for the NHS had written to every head of nursing, every medical director, every chief executive in the country on this very issue of fit testing to make sure that it was being done properly and that the issues that Helen describes were taken into account. So it certainly wasn't something that took the Prime Minister on the 30th of April to raise. It was already being specifically addressed and we were very concerned about it. As to the specific, as to my remarks in the meeting, I think I take it from what Helen said that she wasn't at the session itself. So that's not what I actually said. And if we could pull up the minutes of the meeting, then I think that will show itself. So it's actually INQ 88643 on page 7.
Sorry to interrupt you,
right.
But so as far as I'm aware, we haven't.
It's on your system. Can I just at least read it then, even if you're not going to put it up on the
that's
screen?
what I was going to suggest.
Okay. So actually, the Cabinet Office's own minutes of that meeting say, first of all, that the Permanent Secretary at the Department of Health and Social Care responded on the availability of PPE, given that the Department of Health and Social Care has responsibility for securing PPE for the NHS. And then it goes on to say, the Chief Executive for the National Health Service said, there was ongoing work to investigate the suitability of PPE for all those using it and testing to make sure it was suitable for women, for those who are Black, Asian, and from minority ethnic backgrounds, and those with different face shapes or facial hair. So I think the Cabinet Office's own records show that what is attributed to me secondhand is not actually what I said at the meeting.
Right. Well, that's very helpful. And so the answer that you gave to the Prime Minister was perhaps a holding response, saying that there was a problem, but that you were looking into it.
Yes, and the minutes of the meeting as well from the Cabinet Office set a specific action, which was that the Department of Health and Social Care should confirm that PPE had been procured and was fit for purpose for staff in response to reports that gowns did not fasten as they were too small and that certain items did not fit women. So this was specifically being addressed.
And what we know, and we can see in other evidence, is that in fact this issue of misfitting PPE continued to be a problem for weeks, months, even years afterwards, didn't it, Lord Stevens?
I don't know about years, but it definitely was a problem as a result of the short supply of PPE overall, with the result that it was often very difficult for DHSC to get sufficient range of masks in different locations at the right time. There's no doubt about that.
Well, just finally, let's look at one last document, which is INQ 97875. A letter written by the BMA to the Chief Executive of Public Health England, so to be clear, not either you or your organisation, but dated January 2021, not quite a year after that meeting. And if we can go to the second page, please. We see the last substantive paragraph. We have written separately to DHSC to raise concerns about PPE failing to meet the diverse needs of the medical workforce, in particular that many female doctors have reported struggling to find respirator masks that pass fit testing. So the message that you had given to the Prime Minister that this was being looked at, I think that's a fair summary of the minutes.
Well, not just looked at, that action was being taken to try and resolve the problem, given the pressures on the supply of PPE, yes.
And was action still being taken to try and resolve the problem all those months later in January 2021, Lord Stevens?
Well, as you say, that was not a letter I don't think I saw because it was sent to Public Health England. And I think the specific point that Dr. Nagpal is raising in that letter is whether or not there should be a change in the rules or the recommendations for what type of PPE should be being worn. I think he specifically says that in the letter. And I'm sure the reason this was addressed to Public Health England is they set those rules and then everybody else sought to follow them.
Yes, thank you very much, Lord Stevens. Thank you, my lady. There are some questions to be asked by core participants.
Thank you. Mr. Weatherby.
Thank you very much. Lord Stevens, I am going to ask you questions about that final topic on behalf of the COVID Bereaved Families for Justice UK.
Yep.
And just picking up on that, your answer to Mr. O'Connor regarding the lack of appropriate fitting PPE for women, but also for people from black and ethnic minority workforce, is that by the time it's raised with you, there's ongoing work. Is that right?
Well, I think, yes, essentially, yeah.
Yeah, okay. So there's two issues here. First of all, in January and February of 2020, NHS England did a stock take, I think, of PPE. Is that right?
No, I think that was Public Health England and
Right.
the Department of Health and Social Care, because
Okay.
Public Health England was responsible for creating and overseeing the PPE stockpile
Yeah.
that supposedly would be sufficient if a pandemic struck. And
Yes.
as we all now know, it wasn't.
It wasn't sufficient. So
Correct.
and as the Chief Executive NHS England, that would be a major concern to
Yes.
you and of great relevance, whoever did the stock taking.
Absolutely.
Yeah. So that's sufficiency. So first of all, it's insufficient. But this point about fitting face masks and also training to use PPE is a further important point, isn't it?
Yes.
So it's sufficiency on the one hand, but also even if you have lots of it, if it doesn't fit or if your staff don't know how to use it, then that's an additional problem.
It is, although the 2 points are somewhat related in that if you can't be certain of getting the same type of face mask or PPE with each delivery because there's a shortage, then that is probably one of the root causes of the problems that I think you're describing.
Yes. So if you know about the problem in advance, then the sufficiency of different types of PPE should be catered for.
Absolutely.
Yeah.
Now, of course, as you know, what was actually happening at this time was there was a worldwide scramble for PPE, given that the
Yes.
UK's stockpile was not sufficient.
Yes.
And the Department of Health and Social Care, the Cabinet Office, Department of International Trade went on a huge buying spree to try and secure us
Yes.
the PPE we needed.
So at this point, the stable door was open and the position was trying to be recovered.
Yes.
And it was difficult because there wasn't PPE available, even if you knew what you needed.
Yes, I mean, I think the national position and the National Audit Office looked at this, and I think their conclusion was that no individual item had a national stock out.
Yes.
But I think that's only part of the story, because obviously if you're really up against it, then the ability to get PPE to where it's needed at the right time for the right person is much harder.
Yes, and the management of it is something that no doubt the inquiry will be going into, as Mr O'Connor indicated in a future module, but an important point. But it's right, I think, that in 2016, NervTag had made a formal recommendation to the Department of Health that there should be a rolling NHS programme for the fit testing of respirators, FFP3 masks, as an important part of infection control. That's right, isn't it?
I'd need to see the NervTag papers. I'm not disputing that, but I need to see them. Yeah.
As the Chief Executive of NHS, this is something directly relevant to you. Let me put it up on the screen, and hopefully that will jog your memory. 22737, please. And as you can see, the heading of it, NervTag subcommittee on the pandemic influenza. So directly related to pandemics and face masks and respirator stockpile. And then formal recommendations to the Department of Health. And then I'll try and deal with this quickly, but if we can go to page 2. I'm so sorry. It's the bottom of page 1 and then 2. Have you got that? So under discussion points and stockpile, fit testing in the face of an emerging pandemic is a major challenge. And then going over the page, the point I'm trying to get to is the first bullet point. Just-in-time fit testing was proposed. However, there may not be sufficient time to put this in place between pandemic virus emergence and the first UK impact. It was agreed that there's no substitute for a rolling programme of fit testing in NHS trusts during inter-pandemic periods. There should be a caveat about fit testing and any recommendations. Okay? Does that help you in terms of the knowledge about this?
Well, I mean, this is the first time I've seen this document, but yes, I can read what you've put up there.
But you were in Chief Executive from 2014.
Sure, but this was a document, I think, to Public Health England,
yes.
The Department of Health and Social Care, wasn't it?
Yeah. Fully take that point.
Sure.
It directly relates to the NHS. It's a recommendation that the fit testing rolling programme should take place across the NHS, and you're the Chief Executive.
Yeah, and it may well be, but I do not want to give you an answer that is not fact-based. I can certainly ask that question and make sure you get that answer. But clearly, if just really skimming this document now, seeing it for the first time, it appears to be suggesting that fit testing was obviously specifically confined to intensive care units. The issue with COVID was obviously that it was a much wider set of requirements. And frankly, the pandemic planning for influenza flu was wide of the mark for the sort of PPE requirements that COVID brought about.
Yes, Lord Stevens, this is a document related to pandemic flu. it's related to PPE, it's related to a recommendation for a rolling programme across the NHS.
Sure, but the
Did
point-
you know about that recommendation or the issue?
And I didn't know about that specific recommendation.
Yes.
But just to be clear, the recommendation in respect of pandemic flu, it was a completely different set of PPE requirements. Well, not completely, but substantially different. And the type of staff who would be involved in this type of fit testing, as I think this document itself suggests, were different than what we ended up with. So look, there's no doubt that...
We're talking about respirators with a respiratory virus.
Yeah, well, I mean, I'm talking about the aerosol generating procedures, but also the use of these PPE in far wider settings than, frankly, was envisaged for the flu stockpile. And that's one of the great misjudgments, essentially, that was made and resulted in the fact that when COVID struck, we did not, as a country, have the PPE we needed.
Okay, let me just focus my question then. That you told us that by the time it's raised with you in April of 2020, there was ongoing consideration about fit testing and the propriety of the types of PPE that you had. Was there a rolling programme of respiratory fit testing during the period from 2016 to the 2020?
Well, I think it's likely there would have been in those parts of hospitals and health services that were using that PPE. But as I say, I don't want to speculate. Let's find out the facts and get those to you.
Yeah, okay, well, that's very helpful. It's just that when you said that there was ongoing work, you obviously did look into this in April of 2020.
Yeah, that was ongoing work as
Yes,
been
I understand
recommended
that.
for COVID. Yeah.
I understand that, but did you understand when that ongoing work had started?
Well, this was specifically in response to COVID, where a far wider group of health service staff were needing PPE.
Yeah.
So I think that's what the Chief Nursing Officer
Yes,
and the National Medical Director were focusing on.
Of course, the context is COVID. That's what you were dealing with.
Yeah.
But it was about respiratory respirators and other PPE, which went rather beyond COVID, didn't it?
Well, as you know, there was a live and indeed ongoing debate, which I was not directly involved with, but a scientific debate as to the circumstances under which it was appropriate to use the type 2R mask as against the FFP3 masks. Okay. And I think it's the FFP3 masks that you're referring to specifically here.
Well, I think that's something that possibly we'll leave to a different module, the granular detail of it. But finally, this. Had there been a rolling programme of fit testing across the NHS, do you agree with me that these problems with non-fitting PPE for women healthcare workers or black and minority ethnic healthcare workers would have been flagged up much earlier and would have been dealt with or should have been dealt with prior to the pandemic?
No, I think almost the reverse, because if you were doing it in a situation where there was ample PPE supply because there wasn't a pandemic on, you wouldn't actually have detected the problem. It was only when the shortage arose that it was so evident that there was a problem.
Those are my questions.
Thank you, Mr. Wetherby. Ms. Harris.
Good morning, my lady.
Good morning.
Good morning, Lord Stevens.
Good morning.
I appear on behalf of Covid-19 bereaved families for Justice Cymru,
Right.
representing bereaved families in Wales.
Mm-hmm.
And I'd like to ask you some questions relating to just two areas, if I may. First of all, in relation to hospital discharge, and this is said, as Mr. O'Connor's already highlighted this morning, that the details in relation to discharge into care homes are going to be dealt with in another module, but they are to some extent dealt with in this module. I wish to ask you about one particular aspect to do with the discussions that preceded the policy or the guidance in March 2020 with regards to discharge and the impact on social care settings. You have To introduce my question, I would just like to ask you to recall that in your witness statement at paragraphs 31 to 36, you have referred to a series of fora where there were discussions of the matter of measures to free up hospital capacity. Mm-hmm. And you have referred, that includes a discussion in Cabinet on the 17th of March. I think you said earlier that you didn't attend that particular meeting. You've also referred to a meeting on the 18th of March 2020 with the Prime Minister. I don't know whether you immediately recall that meeting. It might be helpful if you do recall whether you attended that particular meeting on the 18th of March. Your reference to it, I think, is that it was specifically in relation to the matter of NHS resilience and a meeting on NHS resilience with the Prime Minister on the 18th of March 2020.
Yeah, I mean, there have been meetings with the Prime Minister before that as well. So this question was, for example, also discussed with him and others on the 12th of March. I know it was discussed in the Department of Health and Social Care with Matt Hancock, with the HSC officials, some of the senior doctors in the department, social care advisors and so on.
Thank you.
But I was not at that 11th of March meeting, I don't believe.
Thank you for that. And the guidance itself was published on the 19th of March, and that is referred to in your witness statement as the hospital discharge, the multi-agency hospital discharge guidance. And is it correct that the purpose was to secure swift discharge of hospital patients who were considered to be no longer in need of to be in hospital, to secure their swift discharge, and this included envisaging that there would be a considerable number of individuals who would be discharged into social care, including care homes?
Not that more people would be discharged than would normally be the case, but just that the discharge would not be delayed in the way that, as we've discussed earlier this morning, was often the case.
Thank you. In terms of the impact of that guidance, I'm noting that in paragraph 32, you have quoted specifically to free up hospital beds, over 30,000 patients were expected to leave hospital into social care imminently.
I don't think I've quoted that, because I think actually it was the original modelling was that 15,000 of the bed capacity would be as a result of postponing routine surgery, and then if it was possible to get better support for people at home and social care, which the government funded and changed the regulations on, then that would mean people who would have gone to social care back home or care homes would be able to do so faster rather than slower, as had been happening up until then. So about half of that, I think, was attributed to the length of stay reduction, half of the 30,000.
Thank you. But in any event, it was part of the picture that was envisaged resulting from the guidance that there were going to be individuals discharged from hospital into care home settings.
Well, people are obviously, if people have been living in a care home, then when they're ready to go home from hospital, they would return to their care home. So it wasn't a new group of people who would be going to care homes who would not otherwise have done so. It was just trying to take out some of the delays in the system. And indeed, of course, the actual number of people who returned from hospitals to care homes went down in this period, not up.
If I could just pick up on one point there, there would be some new admissions to care homes as a result of this policy. Would you not agree?
I don't agree, no, that there would be a higher number of people newly or returning, going back to care homes. It's just that the delays of being stuck in hospital would be reduced.
But we agreed in any event that there would be people who would be discharged from hospital into care homes.
As always, yes.
And the question arising out of this is, what discussions were you aware of or party to with regards to the risks for residents in care homes arising from discharge plans in terms of infection?
Well, I think, as I say, I know there was a discussion at the Department of Health and Social Care with ministers and senior doctors on the 11th of March. I also know that over the following days there was a discussion about whether the risk was greatest if people were about to need hundreds of thousands of hospital beds and instead were going to, as we'd seen in northern Italy at that time, be left in hospital car parks dying. So there was a risk the hospital beds weren't available. I think there was a related but separate decision that the Secretary of State took, which is if you're going to have testing, how should you allocate a limited number of tests? And I think the Secretary of State has said that he made that decision on the 11th of March as to who would be prioritised, and that did not include people being discharged into care homes. He did so on clinical advice, but that was the decision that he took.
Yes. And in the context of there not being testing, was there a discussion that you're aware of or were party to of the issue of possible asymptomatic cases of infectiousness going into care homes and the impact that that could have? Was that specific discussion had about that specific type of risk?
I understand, looking back on it, based on some of the materials that I've subsequently seen, is that there was a discussion involving some of the senior clinicians, and there was a balance of risk argument. I think they also contend that although the possibility of asymptomatic infection had been identified, it was not known how substantial a risk that was at that point in time. That is obviously something that there are conflicting views on, and I'm sure rightly the inquiry will want to look at that in very great detail when the inquiry comes to care homes.
So just to clarify, are you saying it was recognised that there was such a risk from asymptomatic discharges, even though there was uncertainty around the extent of asymptomatic infectiousness?
I think potentially different people had different understandings of that, and I don't have a comprehensive overview as who was saying what, but I think that was in some senses taken into account, but whether it was appropriately taken into account, that's obviously something that, again, the inquiry will have to look at very carefully.
Yes, thank you. And just on that question of whether it was appropriately taken into account, as you view matters, whose responsibility was it primarily to initiate consideration of the taking into account of that matter?
Well, I think, as was referred to earlier, this is something that the High Court has independently looked at, and I can't second-guess their judgment. That their assessment was that it was reasonable for ministers to free up hospital capacity, and it was reasonable for ministers to make the prioritisation of testing decisions that they did, but that what should have happened was clearer guidance to care homes about isolating people who were coming back to the care home. That's what the court found. I also defer to the medical evidence that is contained in the Chief Medical Officer's review of this matter, and their assessment is that the majority of the infections that tragically entered care homes came from the community rather than from patients returning to them.
Thank you. And I note, and I think I'm nearly at the end of my time, so I think I'll have to finish very quickly on this. But it's correct, isn't it, that report also does note, that very report, which I know you have referred to in your witness statement, it does also note that some care home outbreaks were introduced or intensified by discharges from hospital.
Yes, the report does say that. The overarching evidence, I think, is that unfortunately in any country where COVID is out of control in the community, it found its way into care homes, and that was true in many countries around the world.
Thank you. I think I've come to the end of my time, and many apologies if I went over. Thank you.
Thank you, Ms Harris. Mr Metzer.
Thank you, my lady. Lord Stevens, I asked questions on one topic only on behalf of the long COVID groups. In your evidence, you said that solely viewing the amount of COVID through the lens of whether or not there were enough NHS beds was wrong, and the right question, you said, was how you control the numbers of people infected. Linked to that, I wish to explore with you long-term morbidity from Covid-19 infection, which is another metric of harm in the pandemic. Mm-hmm. NHS England announced the Your COVID Recovery Platform on the 5th of July 2020, which was a platform to support patients suffering from prolonged symptoms after infection from COVID-19. Would it be right to say from this announcement that by July 2020, the NHS were concerned about the prevalence and risk of long COVID?
Yes.
Thank you. Would the NHS have been assisted by a public health messaging campaign on long COVID at this time?
So I think I'd break that question into two parts, if I might. There'd be public messaging for people who might be experiencing what came to be known as long COVID, so that they were able to come forward and engage with services. But perhaps the second part of your question is a different one, which is, would it have made sense for the government to talk about the risks of long COVID as a way of trying to encourage people to take action to limit the spread of the virus? Is that what you're saying?
Yes, it's really
right?
about the assistance that will be given to the NHS by messaging coming from the government.
Well, I mean, the root cause of the problem, obviously, is the amount of COVID infection. So I think, there was a clear understanding that less COVID is better.
Yeah, but long COVID comes from COVID infection.
Indeed.
So do you agree that the NHS, therefore, would have been assisted by such a messaging campaign?
Sort of telling people about the existence of long COVID, so people, therefore, were sort of appropriately cautious about their interactions. Is that
yes?
Is that the thought of? Yeah, I mean, but possibly yes. I haven't. I mean, possibly.
In August 2020, NHS England published a detailed briefing note on managing the long-term effects of COVID-19. The paper estimated that a significant number of the UK population will need some form of rehabilitation support for ongoing conditions over the year, and long COVID is described as a new healthcare challenge requiring actions to strengthen NHS services to meet new demand. Do you agree that by August 2020, the NHS were concerned that emerging evidence of longer-term sequelae of COVID-19 would pose an additional cost to the NHS?
Absolutely.
And was the new healthcare challenge and its associated cost communicated to Number 10 and the Cabinet Office?
Well, in as much as we were making public announcements and they would have known we were making the announcements about the NHS services that are being responded, yes, I'm sure they would have been aware.
So assuming that your answer is you agree, how, if at all, did the decision makers respond?
Well, I think the Department of Health and Social Care shared our concern, and I know that senior clinicians, ministers over the summer and into the autumn were also engaging with the question of long COVID and how appropriately to support, and there was a sort of active dialogue between the Department of Health and Social Care and us in the NHS about what that should look like. I can't say what the discussion was between them and the central government, though.
So does that mean you're not able to say how the decision makers, those in Number 10 in the Cabinet Office, responded?
That's right.
Thank you very much, Lord Stevens. Thank you, my lady.
Mr. Dale.
Thank you, my lady. Lord Stevens, I ask questions on behalf of FEMO, the Federation of Ethnic Minority Healthcare Organizations. One of FEMO's main concerns is about the UK's pandemic response and what it perceives as a seeming lack of urgent, centralized, and coherent programmatic response to the spectre of disproportionate deaths of Black, Asian, and minority ethnic healthcare workers and their wider communities, and certainly at the early stages of the pandemic. And as such, I have 4 discrete sets of questions for you. And my first question is, when did it become clear that Black, Asian, and ethnic minority communities were disproportionately being affected by COVID-19, specifically in terms of the death rates?
Mm-hmm. I think, sorry, I'm not quite sure. I don't want to turn my back to you, but I probably...
It's not impolite. That's been established.
Apologies.
Because of the microphones, Lord Stevens, so...
Oh, right. Okay. Apologies then.
He won't consider it an insult, will he, Mr Dale?
Right. I think the answer to your question is sort of early spring, and to be precise, more precise about it, I know that, for example, on the 9th of April 2020, the NHS National Medical Director, Professor Stephen Powis, having seen some of those emerging figures, as you rightly describe, raised the concern about the disproportionate impact at the senior clinicians group. And on the strength of that, I believe that Chris Whitty, the Chief Medical Officer, commissioned Public Health England to investigate more fully.
And that speaks to an sort of investigatory response for perhaps a more reflective response to this phenomenon. I want to button down on that in particular and ask you, do you consider that there was a timely response to this phenomenon?
Well, in terms of what the health service was doing, I think this matter was raised with me at about the same time as Steve Powis discussed it with those other senior clinicians. And in fact, I had a very important letter from a group that I respect immensely called BAPIO, the British Association of Physicians of Indian Origin, again, probably around maybe 9th of April, something like that, and also from Dr. Chand Nagpal at the BMA. And so I pretty immediately convened a meeting with them and other stakeholders to say, what do we think is going on? What is the action that is needed? And we held that meeting on the 15th of April 2020.
From your vantage point, was there an escalation of concerns around this issue? And in answer to Mr. O'Connor's questions, you spoke about regular meetings with the Prime Minister, for example. Was there an escalation in terms of how this issue was addressed, or what the response was?
Well, I think there were maybe there's an element that obviously relates to what we were seeing in the NHS, and then there's an element that relates to the information that people like Public Health England and others were showing about in the community, the disproportionate impact on people who are getting COVID and dying. In terms of the first of those, what we were doing in the NHS, obviously we were able to take action in respect to the second of those, the broader impact on the community. I think that is a question that I can't answer, and that's probably a question for Department of Health or Public Health England as to the extent to which the centre of government was having a policy discussion with them about that. I don't know.
And finally, can you tell us about any specific targeted intervention that was put in place in those early months to address disproportionate death rates among Black, Asian, and minority ethnic communities?
So within the NHS, on the 17th of March, we asked every part of the NHS to make sure that staff at higher risk of COVID and having a bad outcome from it were identified and were able to work in lower risk areas. We followed that up on the 29th of April and the 30th of April with a request that specific risk assessments be done across the service. And then at the same time, I think I commissioned Professor Kamlesh Kunti from the University of Leicester with colleagues to identify specific risk reduction frameworks that would take account of the extra risk that appeared to be in place for minority ethnic staff. And that was produced in combination, I think, with the Faculty of Occupational Medicine.
Thank you. Thank you, Lord Stevens. Thank you, my lady.
Thank you, Mr. Dale.
Lady, those are all the questions for Lord Stevens.
Thank you very much indeed, Lord Stevens. Thank you for your help.
Thank you.
I'm not going to rise, but I'm told that the stenographer would like, so we're going to take our time in the handover.
Milady, the next witness.
No, I'm
gradually.
not allowed to say anything. I'm giving the stenographer a rest.
But it'll take some time to put the papers back together again.
Right.
I do solemnly, sincerely and truly, declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Could you give the inquiry your full name, please?
I'm Sir Christopher Wormold. I'm the Permanent Secretary of the Department of Health and Social Care.
Sir Christopher, you are known to the inquiry, of course, because you gave evidence in Module 1, an event you'll no doubt recall. Thank you for your continued assistance. You've provided a number of additional statements to the inquiry. We don't need to bring them up, but 4 statements in particular relate to the subject matter of Module 2, and they run to many hundreds of pages, in fact. So, Christopher, members of the public won't know, but in preparation for your evidence today, the inquiry provides you with particular documents on which it intends to focus. I know that you were sent those documents over the last few weeks, but in particular, you were sent a number of documents up to and including late last night. You may not, therefore, have had a full chance to consider those documents. I apologise that you received them so late. We're just going to go through them and we'll just see where we go. I also want to make plain that my questions of you are directly focused on Module 2. The Department of Health and Social Care was, of course, the lead government department in this health emergency. But Module 2 focuses on the core political and administrative decision-making at the heart of government throughout the currency of the pandemic, and therefore we'll be looking at those areas in which the DHSE engaged with central government or gave advice to central government or met with central government, as opposed to looking at matters which were specific to the DHSE alone. You follow?
Yes.
Can I also make plain, because of some of the questions which have been put to the previous witness, that, of course, matters concerning the detail of test and trace, the care sector, and PPE will be addressed in detail in later modules held by this inquiry. And therefore, we won't be going into the granularity of any of those areas. We'll only be looking at them insofar as they reflect the core administrative or political decision-making. With that context, could I ask you, please, to start by describing the role of the Permanent Secretary, and in particular, your role as a Permanent Secretary in the DHSC in January 2020.
Yeah, thank you. And if I may, I'd like to repeat what I said in Module 1 about the Department's regret for everyone who's suffered either directly or indirectly as a result of COVID, and also our enormous thanks to the incredible staff in the NHS and the care sector and everyone who helped them and got us through the pandemic.
Also, if you would, could you go much more slowly, please?
Oh, sorry.
I'm afraid our stenographer's had a tough morning already. And
Right.
I think she might kill me if I let you.
I'm very sorry.
So, Christopher, you know, of course, from this process before, the absolute need to go slowly.
So the role of the Permanent Secretary I see as always in three chunks. You are the chief executive of the DHSC itself, and you lead the staff and systems of the department. You are the chief advisor to the Secretary of State, who holds all the actual legal decision-making powers. Which does not mean you provide all the advice yourself. Indeed, you provide very little of it yourself, but you're responsible for the system of advice. And thirdly, you are the accounting officer for the resources voted by Parliament to the Department to fulfil its functions. And it's basically those three things.
Just briefly focusing on some of the moving parts within the department, the inquiry is, of course, extremely well aware of the vital role of the chief medical officer, the principal medical advisor to the government. To what extent is the CMO part of the DHSC or an advisor to the DHSC?
He is a completely integral part of the department. But also has a wider role across government. So he is one of the most senior staff of the department, ranked at Permanent Secretary level, part of the executive team that leads and runs the department. He advises the Secretary of State on particularly public health, but actually any clinical matter relating to England. And then he's advisor to both the Prime Minister and the entire Cabinet on clinical matters relating to both England and the United Kingdom. So if another Cabinet Minister requires clinical advice, they would go direct to the Chief Medical Officer, not via the Department, and likewise with the Prime Minister.
The inquiry understands that as a result of the demands of the pandemic, a second permanent secretary position was created within the Department of Health and Social Care. But did you remain primarily focused on COVID, whilst that other second permanent secretary dealt predominantly with other aspects of finance and group operation and the many areas?
Yes, though it evolved over the period. So the original idea...
Shortly, please, Sir Christopher, did you remain responsible for the COVID, in general terms, COVID issues? You refer to the important part of the Permanent Secretary's role in providing advice to ministers in the department. Presumably that includes the Secretary of State.
It's primarily the Secretary of State, supported by the junior ministers. I would normally be most involved with the Secretary of State.
And how does it work? Does the Secretary of State, whoever they may be, receive advice exclusively from the department in the discharge of their function as Secretary of State? Or are there other sources of advice or information or material which they may be privy to or receive from elsewhere?
So Secretaries of State are free to take their advice from wherever they like. That might be other parliamentarians, it might be independent experts, and it might be other cabinet ministers. There would always be official departmental advice, but Secretaries of State can choose to supplement that if they wish to. So, as a department, as a civil servant, you have a right to be heard. You have a right to put your advice to a Secretary of State, but not either that advice is necessarily followed or that is the exclusive advice that a Secretary of State would receive.
On matters specific to the Department of Health and Social Care, for example, relating to test and trace, or the care sector, or PPE, all of which the DHSC was centrally concerned in, would the majority, if not all, of the information received by the Secretary of State come, therefore, from the department?
Certainly the vast majority, but to take an example, were a Secretary of State to wish to supplement some advice on social care by talking to a local authority director of social services about what it felt like from the local authority, and they're completely free to do that. But it would normally be a supplement to advice received by the department. And as I say, the vast majority would have come from departmental sources.
And the Secretary of State wouldn't go off on his or her own and speak to somebody else without the knowledge of and possibly the attendance of a member of the department, or that process of meeting and the receipt of information being recorded by way of email or departmental note.
Yes. So the rules in force is if a Secretary of State or any minister feels they have had a conversation which is relevant to public policy, they either have a private secretary in attendance who records that, or they feed back to their private office who record the conversation. And the test is not who was the conversation with, but is it relevant to the public record?
Your statement makes plain, or one of your statements makes plain, Sir Christopher, that the Permanent Secretary is usually copied in on all advice to ministers. And of course, one of your primary responsibilities is to ensure that ministers receive the right advice at the right time.
Yes.
So you are, of course, aware that a number of witnesses in this inquiry from the Cabinet Office and Number 10 have given evidence to the effect that the Secretary of State for your department regularly said things that were untrue. I want to ask you, firstly, therefore, whether you were aware during the pandemic of that view apparently held by other people in the heart of government.
So there were two things that were raised. There were a very small number of cases where people said the Secretary of State had said something that was untrue. I have to say I did not either witness or come across things where I thought you said something is actually untrue. There were a lot of people who said that the Secretary of State was over-optimistic about what would happen and over-promised on what could be delivered. That was said really quite a lot. I think it was a very small number of people who said that he was actually telling untruths.
The proposition I put to you was that there were a number of witnesses who have said that the Secretary of State regularly said things that were untrue. And I asked you whether you were aware that that was their belief. Do we take it from that last answer that you weren't aware that witnesses, civil servants, advisors in the heart of government were saying that the Secretary of State regularly told things that were untrue?
Regularly, yes. I had individual instances raised, and as I said, I couldn't see any validity to the accusation on the individual things that were raised. I didn't have it reported regularly untruth. The other category I did hear about a lot.
So, in fact, your answer is regularly no. That's not something. You didn't hear that people were regularly saying he was speaking untruths?
No.
All right.
Not untruths. You know, as I say, my two categories.
We understand.
Carefully.
When you gathered that there were instances of untruths, as you've described, and more, perhaps multiple occasions of exaggeration or matters being not quite right, being said by the Secretary of State, what did you do in terms of speaking to him?
So when you come across something where you think either in public or to a cabinet committee, something that is not true has been passed on. I mean, in the vast majority of cases, it's accidental. And in those cases, you have to put the record straight, as it were, and ministers do this quite a lot in Parliament and also in the cabinet. I think, misremembering a number, for example. Sorry.
Yes.
Yeah. In terms of the second category, I mean, that is a matter of perception. I'm sure Mr. Hancock will say he believed that what he said was deliverable, and in particular, and he did make a big thing of this, his style of leadership was to set very hard challenges as a way of motivating the system. So this came up most probably around the 100,000 tests pledge.
We'll come back to that in detail, but my question to you was, what did you do in terms of speaking to Mr. Hancock when you became aware that there were instances of untruths and more often examples of exaggeration?
Well, as I say, there weren't instances of untruths which I raised with him. There were things he corrected, but as I say, when on individual cases when they were raised, I couldn't see what untruth had been told. On the setting, on the other category, we spoke about that, and he was always clear that he was doing it for a positive reason. So setting a very aspirational target, not necessarily expecting to hit it, but to galvanise the system to do more. So that was well, you will ask Mr. Hancock, I'm sure, but my understanding that was a sort of conscious decision. And of course, whether that's a good thing to do or not, that is a matter of perception, not a matter of right and wrong.
So, Christopher, I've asked you about instances in which you agree he may have exaggerated the position. I wasn't asking about the setting of targets. I'm asking about instances in which you became aware that the Secretary of State had said something which just wasn't accurate, whether it was in terms of numbers of tests or things being done or things being done by the DHSC, which may thereafter have required correction. What did you do when you were confronted with those instances?
So for those, which are the first category, I tried to satisfy myself whether it had happened or not. And as I say, when I looked at the individual incidents, I couldn't identify examples where he had said something that was untrue. So to take an example, he was accused of misleading the Prime Minister about whether people being discharged from hospital into care homes were going to be tested. When I looked at that, I couldn't find any evidence that he had done that. I didn't witness it, and it had been stated in public that we were not undertaking such tests. So I couldn't see how there had been any misleading going on. And in that case, there was therefore no further action to take. So, as I say, I didn't find any instances where he told an untruth that you could identify that you then needed to put right.
But there were instances, weren't there, to use the wonderful phrase of one of your professional former colleagues, I think it was Lord Armstrong, where he may have been economic with the actuality?
I'm trying to think of a specific example. I couldn't point to a specific example. As I say, the things that were mainly raised with me were at the level of your Secretary of State promised 100,000 tests by the end of April. We don't think he's going to get there. It was much more that sort of over-promising in the future as opposed to something that is not true. Now, in that case, it's, of course, a matter of opinion, and the Secretary of State is entitled to his opinion that he will hit his target. But so the things that were raised with me, they were much more in those sorts of category of over-promising as opposed to untruth.
Did you say to him, Mr. Hancock, I'm now aware that there are a significant number of people, senior civil servants and advisors, in the heart of the government seeking to respond to this appalling crisis, who believe that you are saying things regularly that are untrue, or you are exaggerating, or you are simply giving a wrongful impression about the reality?
Not in exactly.
If you just let me finish my question.
Sorry.
And therefore say to him, this is damaging to the trust and the confidence which your colleagues must necessarily repose in you, and this is doing us and the department harm.
So we had conversations, and I couldn't point you to a specific day, but I remember having this sort of conversation with him where I would say, people believe you are over-promising. And as I say, Secretary of State was always very clear that he was saying what he's saying. A, he believed it was possible, and B, he believed it was very important to be both optimistic and aspirational. And that is, of course, in that category, it's not untrue, but people believe you are over-promising. That is then a decision for him about whether that is the image he wishes to portray. I don't think he was in any doubt that some people thought that of him. I don't think there was. I think, well, you'll find out when you question him. I suspect he will be surprised by how widespread it was. I mean, I think he was very well aware that Mr. Cummings held those views of him and expressed them. I think he probably knew that the Cabinet Secretary occasionally made the same point.
Deputy Cabinet Secretary.
I suspect, I am now guessing about what Mr. Hancock will think, but my guess would be that he will be quite surprised that Helen McNamara had the same views, and I think some of your other witnesses have said the same thing. So I think he will be surprised, as I was. In fact, I hadn't heard that from Helen before either.
All right.
That it was so widespread.
And he would have been in no doubt, would he, about the concern that you expressed as the permanent secretary of his department at the fact that this appeared to be an issue?
I see.
Did you express concern, Sir Christopher, to him, or did you just debate objectively whether or not there was any validity to these?
No, I in those sorts of circumstances where it's not about wrongdoing, I see my role as making sure that the Secretary of State is aware of the position, and it is then his choice as Secretary of State how he wishes to behave. It's very different if you think there has been wrongdoing and therefore breach of the ministerial code, where you have a professional responsibility to raise a concern. So in those sorts of situations, my role is to make sure the Secretary of State knows what is going on to the best of my knowledge, and that if he is behaving that way, he is doing so in the knowledge that it is raising concerns.
So, Christopher, we're not concerned here with code of conduct. I'm asking you whether you said to him, Secretary of State, these concerns, these views, these expressions of opinion about your truthfulness or your accuracy or a tendency to exaggerate or be overly optimistic, however you call it. These concerns have been raised. I, as your Permanent Secretary, am concerned about this because of the impact upon the working relationships between this department and the rest of government, and on the trust and confidence which your professional colleagues must necessarily repose in you.
No, I didn't have that conversation, but as I say, I was not aware of the widespread view that has been expressed to this inquiry by witnesses.
How many times did this conversation, this matter, come up for debate between you? You said you spoke to him. Did it stop?
I can only, and I say I cannot remember the date. I can only remember one conversation, but as I say, we were mainly talking about the views of Mr. Cummings and what he was saying.
So there was one time when you spoke to Mr. Hancock about the views of other professionals in government about him.
I couldn't promise there was more than one. I can remember one conversation, but as I say, what I was seeing at the time was a very small number of people who were not Mr. Hancock's friends saying this, as opposed to a widespread thing around government, as I say, that has been presented to the inquiry.
You're not suggesting, are you, that because they weren't his friends, that they should be treated any less seriously in the concerns that they expressed? Helen McNamara?
No, well, as I say, I didn't know that Helen held those views, and she never said those views to me. It's obviously a very different conversation if you're saying Mr. Cummings is saying A, B, C, D, and you need to be aware of that. That was very different from there were 10 people, including lots of senior civil servants, saying. Now, that second thing I was not aware of at the time and therefore did not have that conversation.
Do you accept that if these witnesses are right, that Mr. Hancock did regularly say things that they understood were untrue, that would have been, was very damaging to the government's operations at this time because of the lack of trust and confidence that his fellow ministers and his advisors and the advisors in other departments and civil servants could place in him?
Yes, categorically, yes. So at the time, I knew that there was some toxic relations both within Cabinet Office and Number 10 and between Cabinet Office and Number 10 and the Secretary of State. What has come out very clearly from your witnesses is it was much more widespread and much more toxic in both of those categories than I knew at the time. And had I known it at the time, your statement is absolutely correct. That would be a big worry. And one of my reflections so far on the evidence that the inquiry has heard is that the amount of time and energy that appeared to be taken up very early in the pandemic on the blame game, that energy would clearly have been better spent solving the problems that the pandemic was bringing. So I recognise exactly the point that you are making.
That is, those questions focus on Mr. Hancock and his relations with other parts of the government. I now want to ask you some questions about the general view taken of the DHSC.
Yeah.
Could we have, please, the witness statement from Lord Sedwell on the screen, 250229, page 39.
Whilst that's coming up, Mr. Keith, could we break at about 1:45?
Yes, of course, Milady. paragraph 148. Lord Sedwell refers to the NHS, and then about 6 or 7 lines down, despite the experience of its political and professional leadership, so that's its ministers and the civil servants, dedicated and determined staff and a surge of civilian and military personnel, DHSC was neither structured nor resourced for a public health crisis of this magnitude. It straddled too many different areas, responsibilities scattered across too many areas. Admirably, people had pulled together and frontline staff and volunteers had performed heroics, but the programmes delivered despite, not because of the legacy systems. And he says he called for major reform. Just pause there, because there is a theme. Mr. Cummings, in his statement, we won't put it up, but he says at paragraph 120, the DHC was overwhelmed by the scale of the crisis in February to May. It didn't have anything like the people it needed. It couldn't quickly build capacity. It was bad at asking the Cabinet Office for help. It was hard for me to know how much of this was Mr. Hancock and how much was structural to the DHSC. Helen McNamara, if we could have this up, 273841, page 30. Page 30, paragraph 56. Thank you. Further concerns were raised by Lee Kane on the communications effort, including further indications the DHSC were overwhelmed or appeared to be, or that the DHC was not able or perhaps not willing to provide anyone into the Cabinet Office to support the team looking at public sector preparedness, to develop the policy on the MPIs or support the coordination effort. And then further down the page, we also mistakenly, it's the fourth last line in that paragraph, we also mistakenly did not appreciate that DHSC had focused and were focusing on DHSC and the impacts of the acute health system rather than the wider and long-term health of the public. I do not think we fully understood this until too late to do anything to really remedy it. And at page 88, paragraph 181, thank you. At the bottom of the page, it was difficult to get the right kind of engagement from DHSC or the NHS. There was an inbuilt reluctance to accept that it was possible to get to a point where the NHS was overwhelmed and or to acknowledge that this would be something that Number 10 and the Prime Minister would need to be across and content with the handling of. And then, I won't bring them up in light of the time, but perhaps one of them will suffice. You'll know that Sir Patrick Vallance, the government's own chief scientific advisor, expressed on multiple occasions in his evening notes views about chaos, operational mess, inefficiency, lack of grip in the DHSC. If we could have 273901, page 594. He refers to an email from within the DHSC describing it as ungovernable and a web of competing parts. So that's 594 of document 273901. It is obvious, Sir Christopher, that the individuals and the personnel did their very best. Much was asked of them, and a great deal was delivered. But structurally, systemically, there appears to be a view quite widely held that the DHSC, in the face of this admittedly unprecedented crisis, did fail to perform as it was expected to do?
Well, let's. There were a lot of points, a lot of different points made in the evidence that you quote, and some of them I agree with, and some of them I do not.
Well, structurally, do you accept the proposition that the DHSC was, to a significant and important extent, chaotic or dysfunctional or ungovernable?
No, I don't think any of those things. Now, the points that were made, particularly in Mark Sedwell's first comment about the nature of the health and care system and DHSC's role within it, I completely agree with and would recognise. And this was the picture that I was seeing. I mean, I'm obviously biased. I was very proud of the work of my department and how it stepped up to the mark. I think the point about the structural questions about how health and care were organised, what levers we had, and in particular, and we covered this in Module 1, and I'm of exactly the same view now, our ability both in the health and care system and in the wider government to surge for a crisis of this size, I do think that was a big problem. So as I say, I recognise all those things. I don't recognise
the overall problem.
Yeah, I mean, for completeness, I mean, we were obviously under a huge amount of strain. We had people working incredibly hard in very difficult circumstances, dealing with something unprecedented, and it felt, at the time, it felt incredibly tough and a huge responsibility, and people were at times very down that we weren't able to get on top of some of the problems. So I'm not going to say this was some sort of perfect, easy situation, but I don't recognise the sort of chaos and dysfunction. I recognise that people working incredibly hard in very difficult circumstances to get on top of huge challenges.
So may it just be a question of degree? You would accept that in significant ways the DHSE did fail to get on top of problems. It was regarded as regarded from the viewpoint of the professional colleagues working with it day in and out at Number 10 and Cabinet Office level as being chaotic or unable to deal with the things that it was asked to do.
So let's break down between the four. As I say, I thought Mark's paragraph, which is largely about the structure of the health and care system, I largely agree with. Helen and he and I had conversations about that. So when I received that piece of paper, I recognised the view as one that had been that I had discussed with him. Helen's views I hadn't heard before. I'm slightly surprised that I hadn't. If she had those views, I would expect her to have raised them. Likewise with Patrick, if he had issues at particular times, as his diary clearly shows that he did. I thought we had, I have huge respect for Patrick. I thought we had a good working relationship, and I would have hoped that he would have raised them directly with me. And then for Mr. Cummings, well, I mean, his views of government, civil servants are long held and very public. So I would put the four pieces of evidence that you've given me in different categories like that.
My lady, that may be.
Break for lunch. I'm sorry we've got to ask you to come back after lunch, Mr. You were warned, I hope.
Yes, I was warned. There are obviously lots of important questions to be answered. So.
Very well, I should come back 1:45, please.